I would like to thank Professor Vincent and the organizing committee for inviting me to speak about how ECMO has been used in COVID-19. These are my disclosures. None are directly related to this talk other than that I will show some ECMONet studies. So what is the role of ECMO in COVID-19? I think this paper that was led by Eddie Fan and Lancet Respiratory Medicine really speaks to the way we approach it, which is we believe that we should have an adherence to the current evidence-based algorithm for ARDS management until there's any evidence to the contrary. And so when thinking about the algorithm for the use of ECMO, this we published earlier in the Lancet Respiratory Medicine, we treat the underlying disease and go through the regular algorithm, including most importantly, a trial of prone positioning unless contraindicated. And then if the patient meets Eolia criteria and there's no contraindication to ECMO, then that is when we would proceed with ECMO. At the beginning of the pandemic, in February, we wrote this viewpoint where we said, and this, remind you, was way at the beginning, the role of ECMO in the management of COVID-19 is unclear at this point. We also stated that ECMO is not a therapy to be rushed to the front line when all resources are stretched in a pandemic, which is a theme to keep in mind. What recommendations were made early on for ECMO during COVID-19? This from the World Health Organization on March 13th, suggesting that patients with ARDS in whom lung protective ventilation strategy fails, ECMO may be indicated. They updated this recommendation in May with the Eolia criteria as the basis for initiating ECMO. The Surviving Sepsis Campaign also recommended the use of VV ECMO or transfer to an ECMO center in those patients who are appropriate. And the Extracorporeal Life Support Organization, or ELSO, we discussed the use of ECMO in the pandemic, saying first and foremost, it also recommends against starting new ECMO centers for the sole purpose of treating patients with COVID-19. And that ECMO should be considered on a case-by-case basis, reassessed regularly, and based on overall patient load, staffing, and other resource constraints. So if it's recommended, obviously, we should begin to prepare for it. And this paper by Dr. Ramanathan in Lancet Respiratory Medicine was a very nice way of outlining how we could proceed with careful planning, judicious resource allocation while providing complex therapeutic interventions, adhering to strict infection control measures. What was the data coming out early? This is a pooled analysis of early reports. These are very early reports published in the Journal of Critical Care. This is only 17 patients, 16 of whom died, so the mortality was 94.1%. Notably, the mortality was for conventional treatment was 71%, and this reflected the crisis in China in the very early phases of the pandemic and was probably not a reflection of what went on there later or elsewhere in the world. However, the early data with poor outcomes in the setting of poor quality data suggested to many that perhaps ECMO should not be used for ARDS in this pandemic. However, we now have accumulating data, and there are two very important studies that are upcoming now that should be out by the time of this, this presentation airs. The first is the Paris experience, this by Mathieu Schmidt and Alain Combe. This is the Paris Sorbonne University Hospital Network. That's 5 ICUs providing ECMO for COVID-19 associated ARDS. And they had complete follow-up 60 days after the initiation of ECMO. And so 492 patients were treated in those ICUs with COVID-19 between March 8th and May 2nd, and 83 patients received ECMO for ARDS. Now, notably, 79 of the 83 were treated at La Pitié-Salpêtrière, which is one of the best and largest ECMO programs in the world, and so in part reflects their experience. The time from intubation to ECMO was 4 days. The PEEP prior to ECMO was 14. Plateau pressure of 32, a high driving pressure of 18, and a low static compliance of 22. PDOF ratio was 60, which is lower than it was in both the Eolia and the Lifeguard study, with a PCO2 of 57. Amazingly, 94% of these patients received prone positioning prior to a trial of ECMO, which is an extraordinary feat. Also, interestingly, 81% of the patients, once they were on ECMO, were additionally placed in the prone position. Only 7% of patients prior to ECMO received steroids, and 20% received steroids at any point during their course. And of course, this is data from prior to the results of the recovery trial. What they looked at was a complete 60-day follow-up on all 83 patients using a multi-state Cox model with a time-to-event analysis. And then they estimated the state occupation probabilities, meaning the probability of being in any one of the 4 following states: dead, still on ECMO, in the ICU but off ECMO, or were alive and out of the ICU, although that didn't necessarily include out of the hospital, and 14 were hospitalized or in a rehab center. This is the stacked probability plot for the multi-state model showing the different states. And at the bottom, you can see the estimated 31% probability of 60-day mortality. And going out to 90 days, the estimated probability of mortality was 36%. So very encouraging results. If we look at a broader international experience, this is the ELSO registry experience, and I want to point out my colleagues Ryan Barbaro, Graham McLaren, and Phil Boonstra, who really did a tremendous amount of work on this. This has been submitted for publication as of this time. Hopefully will be out by the time of this talk. This is from 213 centers across 36 countries. 1,035 ECMO-supported, lab-confirmed SARS-CoV-2, COVID-19 patients from January 16th through May 1st, 2020. We looked at the epidemiology, hospital course, and outcomes with a multivariable Cox model similar to the French study, looking at patient and hospital factors associated with in-hospital mortality given the larger data sample. 90 days of follow-up was performed in all patients from the initiation of ECMO. We do not have post-discharge follow-up as part of the registry, but we did have 90 days after initiation of ECMO. The primary outcome was in-hospital death with a time to event analysis, which assessed, as I say, 90 days after ECMO initiation in order to avoid lifetime bias. Looking at both the full cohort and separately at the ARDS cohort, ARDS is how they were labeled by the data managers who input the data. Some of the patients who were not labeled as ARDS were on VV ECMO, no doubt had it. So let's look at the full cohort, which included a small number of cardiac patients as well. The average age was 49 with a BMI of 31. 3/4 of patients were men, 33% white with 21% Hispanic, 15% Asian, and 14% Black. 30% had no comorbidities, but the most common comorbidity was obesity at 47%, with 24% having diabetes. 79% of the cohort had ARDS, was marked as such. 5% had acute heart failure, 2% with myocarditis, and in an overlapping category, 29% had acute kidney injury. Similar to the French data, it was 4 days between intubation and ECMO. PEEP of 14, peak inspiratory pressure of 33. We don't record the plateau pressures in the registry. The PDAF ratio was 72 with a PaCO2 of 60 as a median. Prone positioning occurred in 60% of patients prior to the use of ECMO. This is a large international study, so that's likewise relatively impressive considering prior data. 72% received neuromuscular blockade, and 96% of patients received ECMO for respiratory indication, with 3% for cardiac and 1% eCPR. The in-hospital death was 37% overall. This is the cumulative incidence of mortality from time on extracorporeal membrane oxygenation with the 95% confidence intervals in the dotted lines. And here are the stacked bar plots of the patients and their disposition after ECMO up to 90 days. And you can see in the red the patients who died up to 90 days. In the orange at the top are those who were discharged to home or rehab, good outcomes, discharged to other hospitals, long-term acute care facilities, and those who are censored are in the middle. This is the Cox model for factors associated with in-hospital mortality, increasing age, immunocompromised status, chronic respiratory failure, pre-ECMO cardiac arrest, acute kidney injury, and the initial mode of either veno-arterial or veno-veno-arterial compared with veno-venous all portended a worse outcome, whereas increasing PDAF was associated with a better outcome. These are the complications related to ECMO, and we compare them initially with the current patient population on the left and the 2019 cases from the ECMO registry, non-COVID, on the right, and you see large differences in pneumothorax as well as membrane lung failure, pump failure, circuit change, and so on. But all of these differences go away when normalizing the COVID data for the number of ECMO hours. So because these patients were on for longer, they tended to have more complications. They did not appear to have a higher rate of complications, which is important for future practice. So the estimated cumulative incidence of in-hospital mortality 90 days after the initiation of ECMO was 37.4%. If we only look at those who had a final disposition of death or hospital discharge, still it was a very similar 39%. There are two other efforts that I think everybody should be aware of in gathering data on these patients. One is the EuroELSO survey on ECMO use for COVID-19 patients throughout Europe, run by the EuroELSO group with Jan Bolovic, as well as Roberto LaRusso and others. These are the countries and the various sites that are participating. Currently, as of August 3rd, there are 173 centers and 1,413 cases entered. And this will be a rich trove of data for us going forward, no doubt. Finally, the COVID-19 Critical Care Consortium, run by John Fraser from Brisbane in Australia, has been a remarkable effort. It's a combination of many different societies: ELSO, ECMONet, Sprinsare, ISARIC, and of course is based at the University of Queensland. This is a consortium of over 330 hospitals across 50 countries and growing, and it aims to characterize all COVID-19 ICU patients, not just ECMO patients, and has already produced some wonderful data, and we hope to see a lot more from this in the coming weeks and months. So the use of ECMO during COVID-19 clearly appears to be reasonable to pursue, and in fact, given the level of data that we have prior to COVID, given the outcomes that we're seeing in both the French data and the ELSO data, it does seem that it is reasonable to pursue in these patients, but clearly we have a lot left to learn and a lot of data to come. Thank you very much.